The topic of mental capacity, I think, cuts to the heart of what it means to be human.
You think about the sorts of decisions that patients, their families, carers and clinicians are faced with, the legal issues, the ethical issues, and you think, well, where is the research that's really kind of capturing that going on?
When it comes down to practice, there's a lot of feeling of being at sea. Work needs to be done in this area to try to support the supporters as well as the people who might be receiving support, to be able to feel more confident about what they're doing in this area.
And unless we have a really rich dialogue about how we can move forward, then I think we are going to go on having a real dissonance between sort of coercion and freedom.
There's a massive potential to improve communication and to make clinical decision making easier.
When we're making legislation, changing legislation, we need advice, and when we get advice, we want it to be good advice, and that's what we got from the Mental Health and Justice Project.
The Mental Health and Justice Project is a 5-year multidisciplinary research initiative funded by the Wellcome Trust. It looks into the complex interface where mental health and mental health care interact with principles of human rights. In this film, we'll explore how the project developed clinical, legal and public policy strategies for 2 fundamental imperatives: to protect people where they can be vulnerable and to respect their agency and autonomy. The project lead is Dr. Gareth Owen.
In interdisciplinary work, these are sometimes called wicked problems, which are impossible to reduce to any one discipline. So law doesn't own the problem fully, psychiatry doesn't own the problem fully, social scientists don't own the problem fully, philosophers don't, etc., don't own the problem. These are all wicked problems, and we've basically got 6 of them.
These problems lead to real-world dilemmas. Barrister Alex Ruck-Keene has contributed to many strands of the project.
So there are too many situations where individuals with mental health problems, or somebody who has been temporarily affected by something which means they can't make a decision, are just in situations where it feels like the wrong decision is being made. There has to be a binary answer. Does this person have the ability to make this decision or give this consent at this point in time, yes or no? And you're always in a position, or you are almost always in a position, where you have to reach some conclusion.
A case that tested us a lot in the early days of the project was a real case, which is in the public domain, of a woman who presented to hospital following a very serious overdose, a life-threatening overdose. The complication came when she decided to refuse life-sustaining treatment on the grounds that she had got to the point of her life where she no longer felt that her life, in her own words, had sparkle. The case caused huge amounts of concern amongst clinicians and eventually went to court. And it was resolved in a way which honoured the decision of the woman to refuse treatment. This is, in many respects, a kind of case that captures what contested capacity means. It's where the perspective of the health and social care profession and notions of rights or notions of self-determination can clash.
Jodie Rawls, a PhD student on the project, researched court cases that involve people with intellectual disabilities. For Jodie, the cases involving sterilisation and contraception really stood out.
I looked at actually all of the cases that had gone through this certain court involving someone with intellectual disability. So, for example, there was one case just from 2018 where the woman involved didn't know that she had an IUD. It had been inserted without her knowledge. I'm not sure how, but she didn't know. And the decision in question, that why it had gone to the court, was whether she should now be told. And the decision was not to tell her because of the impact that might have on her other support relationships. So for me, these cases are raising really important and difficult questions that really interested me and I wanted to explore further.
The project had 6 interrelated work streams, some attempting to unpick how established scientific and medical concepts inform ideas of justice in mental health. Neuroscientist Dr. Steve Fleming is the co-lead on the metacognition workstream.
So metacognition is literally cognition about cognition, or thinking about thinking. So it refers to this broad set of skills and abilities that we have as humans to reflect on and think about ourselves. And so an example of metacognition would be when you're thinking to yourself, will I be able to remember this shopping list, or do I need to write it down? So that's reflecting on how good our memory is. And we know that metacognition can go wrong in various ways in psychiatric and neurological disorders, and that it might have particular relevance for thinking about how people make good decisions.
Professor of Philosophy Wayne Martin led the work looking at the concept of insight, a term often used by clinicians and legal teams when trying to establish mental capacity.
I mean, insight is one of these terms that clinicians find themselves using. It goes way back in the history of psychiatry and to some extent in legal discourse, but it does not have a formal and agreed definition. So if one thinks about the kind of canonical case might be a service user who's diagnosed with paranoid schizophrenia, ticks all the boxes for that diagnosis, but is quite insistent that there's nothing wrong with them. They've got no mental health problem. That creates an obstacle for the clinical relationship, and it raises all kinds of questions, legal questions about that patient's right to refuse treatment.
Some of the work has been global, with all the extra complexities that brings. Dr. Hannah Kienzler led a workstream examining support and independence in the community in Ghana, Palestine and the UK.
This is not a sort of typical, let's say, global health project where you report from the global south, from low and middle income countries about mental health related issues, but rather it is a project where we seek to understand what it means for persons with mental illness to live and participate in their communities, what rights they have, how these rights are implemented, what are the challenges, the barriers to the implementation of these rights, but also the resources that are available to them. And then to think about how societies can ensure the right to live and participate in the community in sort of socially and culturally meaningful ways. I think this is one of the very central questions, and understanding that the right to live in the community and participate in the community is infringed upon in all 3 settings, in the UK, in Ghana, in Palestine, in context where there is war, as in the occupied Palestinian territory, a context where there is increasing inequality, such as Ghana, and then a context like the UK with the highest inequalities, socioeconomic inequalities in Europe.
Also on the team was Dr. Sridhar Venkatapuram, Deputy Director at the King's Global Health Institute.
So we all share this understanding that people with physical and mental disabilities and impairments and illnesses around the world are treated unjustly and very sort of, unfairly, and suffer a great amount, and usually live shorter lives and suffer more physical illnesses as well. So there is fundamentally what we would call a global health problem. But that's not only what we are concerned about. What we were also really interested in, and we're still really interested in, is the structures and institutions that are meant to help people with disabilities, whether they are actually functioning well, appropriate, relevant, effective, etc. In particular, we're really interested in this one particular aspect, which is this international human rights law, and particularly the rights of people with disabilities, and even more focused, this one specific right within, which is called the right to live in the community with equal standing.
Professor of Law Ginevra Richardson provided legal input on this issue.
I mean, the way that the law traditionally has dealt with human rights has been an emphasis on stopping the abuse by the state of individuals, of vulnerable individuals. And it's got quite good at that. That's where the sort of history and tradition of international human rights law has originated. The law is not good either domestically, and even more so internationally, at knowing how to articulate and implement positive rights, rights to services.
To tackle these complex issues, an interdisciplinary approach was needed.
One good example is one of our collaborators on the Mental Health and Justice Project, Tony David. So he's a psychiatrist, a clinician, as well as a researcher. And he has an extensive body of research, really trying to articulate more exactly some of the different factors that come into insight. So he analyzes it as a multi-dimensional kind of concept, and he's generated a way of measuring it using what are called insight scales, of quantifying insight.
Being interested in the topic of insight doesn't necessarily mean you have a monopoly of insight, and so it was very useful to have someone like Wayne really probing the assumptions that I make as a clinician approaching the topic compared to how he would see it in a much more analytical way. And similarly, I can bring a bit of a knowledge of experiments and of cognition into the way he sees insight. So it's been, I hope, a very fruitful two-way street. I didn't realize that this is what philosophers do. That's their work, actually, taking apart your assumptions, your ideas. It's not just, yes, I agree, it's exactly what did you mean by that? And then you have to then respond in kind. So sooner or later, pages and pages are going backwards and forwards.
Independent management consultant Laura Heath was asked to evaluate the interdisciplinary nature of the project.
I think one of the things that makes this project really unique is the richness of the disciplines involved and the perspectives that are being brought, and their willingness to think about how they look at truth, how they look at evidence, how they look at methods, how they think, what attracted them into the discipline, what feels to be right, what are their values about, and how do they hold the disciplinary pull and their expertise, and at the same time stay curious and respectful of the other disciplines and hold some of the uncertainty for long enough. But I think the thing that has sustained them is most of the time to hang on to that sense of shared intent and shared purpose.
So I think what I'll do is, first of all, crucially, the team comprised more than just academics and clinicians. Service users were involved too. Dr. Thomas Kabir leads the Public Involvement in Research programme at the McPin Foundation.
The McPin Foundation had overall responsibility for coordinating the public involvement or the service user involvement in the mental health and justice study. And we did that by facilitating and supporting a group called the Service User Advisory Group. And I and Dr. Tanya Gurgal were co-chairs of that group. The group met regularly throughout the entire course of the study. There was quite a famous quote from Dame Sally Davis, who used to be the Chief Medical Officer, "Nothing about us without us." And that's really the mantra that we try to follow. So we really tried to involve people with lived experience in the project and to make sure that they are center stage in everything that the project was about. And we almost use it as a yardstick that if researchers couldn't explain to us in plain English what they were doing, we did wonder, well, did they understand it either?
I think having service users and carers with sort of first-hand experience of some of the issues that they're looking at as part of the project, I think that's really valuable. And I think another aspect that the researchers have often said is that when they come to us and talk about what they're doing and sort of get our feedback on what they're doing, I suppose it makes them a bit more reassured that they're going in the right direction or doing things kind of the best way and that they're on the right track. And I think they often have looked at different things as a result of talking to us.
I have been so resolutely challenged by the Service User Advisory Group in different contexts. really brilliantly cross-examined in different, when we have to present our work. It's just been fantastic. And really, really pushed. And also have to explain things, you know, difficult concepts to people. That's a good discipline, but also justify things. At the point in our work on Workstream 6 where we moved from setting out, this is how the Court of Protection has thought about things, to this is how we think we should be telling people to do things. So we move from the idea of description at some level to prescription. And I think it's unfeasibly important that if you're going to be, frankly, arrogant enough to do that you do that in part, or in very substantial part, by saying to those people who might be impacted by that sort of move, how do you feel about this?
The Advanced Directives workstream looked at when individuals make advanced decisions to provide guidance for their own treatment. The team worked in partnership with the charity Bipolar UK to conduct a large survey to ask the view of people with a diagnosis of bipolar about a type of advanced directive called a self-binding directive. This is a form of advanced decision-making written by a service user with the help of their care team and even family and friends. It explains what usually happens when they become unwell and what sort of treatment is generally helpful. Importantly, it aims to make sure that a person receives this treatment, even if they no longer have the ability to recognise the agreement that they made when they were well.
We asked people whether they endorsed or rejected the self-binding directive idea and why. And it allowed us to see what ideas were dominating amongst the answers that we received. We found that there was a high level of endorsement for the idea, so 82% out of 565 participants. And the most dominant reason that was given wasn't actually in terms of avoiding practical harms like overspending or antisocial behaviour. People talked more about what we classified as distorted thinking when unwell. What they were talking about was experiencing some type of determinate sort of shift in thinking and impairments of decision-making capacity. More specifically, the levels of endorsement show that there are a significant group of service users in this survey who actually would request involuntary treatment via a self-binding directive. And this challenges dominant human rights assumptions that involuntary treatment is always a violation of fundamental human rights. There were a smaller but significant number who did reject self-binding directives, and it is very important that we recognise that endorsement isn't unanimous and that any provision for advanced directives in mental health has to recognise that there are different views and values amongst different service users.
Dr. Preeti Das worked with Tanya and explains that despite their label, self-binding directives are not as restrictive as you might imagine.
Literally, when you hear the word self-binding directives, it sort of sounds like actually it might be something restrictive or something that might reduce someone's choice, but actually in a way, sort of as a clinician, the opportunity to collaboratively draft decisions about what happens to someone when they become unwell with that person themselves. This study essentially presented the first unequivocal evidence in support of the introduction of self-binding directives. So it was published in the Lancet Psychiatry, and it was published alongside artwork from Beth Hopkins, whose work was in the Bethlehem Gallery and beautifully explores the concept of binding through creative pieces.
So you had really for the first time in the Lancet Psychiatry's history a sort of verbal response and a non-verbal response looking at advanced directives and what they mean to Beth personally and also to the groups that she was working with.
In fact, artists from the Bethlehem Gallery brought a lived experience perspective to the project across all 6 work streams.
Bethlehem Gallery is very unique. It's on site at a hospital, but it specialises really in building a bridge between the outside space and the hospital space. And the artists are experts at doing that. They use their work and their practice to bring people together. And we show a series of exhibitions throughout the year, and we run workshops too.
This ethos of service user involvement across the project has also included a participatory approach, where service users become researchers, for example in Ghana.
So we set one group up in the capital, and then in Kintampo, the smaller town, we worked with some of the mental health workers there to identify people who would be interested in being in this participatory work. And so that meant with these groups, we took some of the research questions to them and discussed those together, what living in the community meant to them, what support meant to them, what independence meant to them, what choice meant to them. And we did various exercises to explore these kind of questions together.
In terms of participatory research, one thing I noticed also in Kintampo, the other part of Ghana, where we had our participatory meetings, I think it took us, on the third meeting, that people started opening up to even tell us, feeling comfortable, talk to us about their issues, the things they feel, should be addressed there. So it's a very painstaking process.
Professor Sir Simon Wesley is a leading psychiatrist and government advisor on mental health policy. A King's Policy Lab brought him together with service users when he carried out an independent review of the 1983 Mental Health Act. The review set out recommendations for the UK government on how the Act and some of its associated practice needs to change.
Mental health legislation is always a tricky balance everywhere between, on the one hand, the desire we have to respect autonomy, our choices, even if they're bad ones, but on the other, the requirement the state has to protect the most vulnerable in society, the very young, the very old, and those with very severe mental illness. So this is always a balancing act. And it's right that every 2 or 3 decades that you review it, because so much changes in our attitudes, in law, and also what's happening in other jurisdictions. And so it was time to update it because it had fallen behind what I think could be reasonably expected. A key area was this issue of making advanced choices, and we got a lot of help from the Mental Health and Justice Project. It was very timely, and I've known several of the key players in that for a very long time. And they ran a policy lab for us at King's that really did help clarify thoughts in the area.
Policy labs are an approach that the Policy Institute developed a few years ago, where we try to bring together all of the different stakeholder groups around a particular issue or challenge and try to come up with some way forward, some way of making progress in that area. So in the policy lab itself, as well as the huge range of expertise from different disciplines across the research team, we also brought in policymakers, including members of the independent review team themselves, as well as practitioners and representatives from charities and other organisations as well, to get a full range of different perspectives on the issues that we were looking at. You don't normally get to see judges. And I think these opportunities to meet people and to speak with barristers, for example, who have to work with the Court of Protection in areas of contested capacity, was enormously beneficial for people.
This policy lab helped translate the research into real changes for people receiving treatment for mental illness. Following the review of the Mental Health Act, plans were made to introduce advanced decision-making documents, giving service users more say in the treatment they receive. Psychiatrist and clinical research associate Dr. Lucy Stevenson is part of a group designing a template for the document and testing how it might work in the South London and Maudsley NHS Foundation Trust. For Lucy, the benefits for service users and clinicians are clear.
For service users who've had a very difficult time in mental health services, who are managing, potentially lifelong, relapsing, serious mental illness, but who've become experts in their own care, they often know very clearly what helps them in a crisis, and it seems senseless not to use this expertise and not to respect the wishes that they have about their treatments, when they're well. And then secondly, it just makes sense from a clinical perspective that we take heed of service user expertise, that we improve the quality of clinical communication around what works for people in a crisis. And the evidence suggests that it can reduce compulsory treatment and that for certain groups it can reduce the economic impact of people presenting in a crisis and reduce inpatient admissions.
The principles of advanced choice Lucy describes are a key pillar of the new legislation and will give more autonomy to service users.
The balance has shifted from the patient having to prove what they want to the doctor having to prove that no, we really can't do that. And if it's a reasonable decision, even if it's not the best decision, they're not going to argue with it because, you know, most doctors are smart people and the things will change and they'll shift more in the patient direction.
The project's influence on changing policies has been seen in other work streams too.
In the work we did with the Mental Welfare Commission of Scotland, we found that in the compulsory treatment orders, that was the paperwork that we were examining there with a multidisciplinary team that included service users and clinicians and lawyers, philosophers. In 76% of those compulsory treatment orders, the lack of insight was listed as a reason why the person had significantly impaired decision-making ability. So to us, that's bad practice. We want to change that, and we've been working with the Commission there in Scotland and with the ongoing review that's underway in Scotland to try to think about how to improve both the law and practice in that area.
The review Wayne is talking about is the Scott Review of Mental Health Law in Scotland. Aaron Chopra is the Medical Director of the Mental Welfare Commission for Scotland.
We also published a commission research brief that explains this work and provides context, particularly directed at the Scott Review and other people in the sector who we think it would be helpful towards. Wayne, myself, other colleagues who've been involved in this paper actually presented that data to the Scott Review. That has had a huge impact because it's allowed that conversation to take place. It's provided the data that underpins ideas. It's allowing a sense of let's pick what might be the most appropriate way of exploring someone's ability or inability to make decisions that might be relevant to whether compulsory powers might be used in their care and treatment.
Policy change isn't the only way this project has made a difference. It's also generated guidelines. Dr. Jill Craigie is a senior lecturer in medical ethics and leads a work stream that considers how to enable legal capacity through supporting people to make decisions.
We're planning 3 different documents, one with broadly the same content, but for decision makers who may have their decisions supported, for policy makers who are looking to develop policy or planning around support for decision making, and those who might be providing the support themselves. Whether it's a family and friends or support workers. And each one of these documents we hope will provide them with the tools for thinking about it themselves.
And sometimes it's been important to find new ways of communicating findings too.
Through our work we are producing different kinds of outputs. There's of course the academic work that we're doing, our journal articles, the conferences that we go to, but then we also have outputs that are much more participatory in nature. In Palestine, we produced an illustrated storybook, which meant collecting the stories together with people with mental illness, analyzing them together, writing them up together, and then editing them together.
We decided on radio dramas because radio is a very widely used medium in Ghana for discussing current events and topics of interest. So we are aiming to do 2 broadcasts in 2 of the major languages used in the capital, Twi and Ga.
All of this work has had an impact on those working on it by pushing the boundaries of their scholarship. From the most senior...
Having done kind of obvious work and studies in your field, you want to take it to the next level. And often that means taking it into areas where there's greater uncertainty, where it's really brand new, where you're having to learn stuff from the beginning.
To the early career researchers.
You know, I feel extremely proud actually of the new generation of scholars really that Mental Health and Justice has produced, and the comfort with which they're showing in interdisciplinary work.
as part of the early career researcher group, I think we've had so many more informal discussions among us, and we all have different backgrounds. I think we come from like 8 different disciplines or something. And I think that's been just really fascinating to see how people think about the same problem, but think about it in a different way and come from a different approach. And I think for me, that's a really positive way to keep you open-minded about your practice. And I can apply that to my clinical practice, but also, of course, to my research practice.
The opportunity to work with a team that was with philosophers, anthropologists, lawyers. I mean, it was very attractive to be able to find a career path beyond medicine, I guess.
The other group of people who say they have benefited are the service users who took part in the project.
So I think the service user advisory group members got quite a bit out of being involved. First of all, I think they got knowledge. I think they had the opportunity to be involved in and to enter spaces which had been firmly closed to them. I think they had the satisfaction of following a research project over a period of years and being able to see it through from start to finish.
As a project, they've been quite keen for this to be a bit of a model, I suppose, for involving service users, to know that it's kind of had a big impact on the work. You know, it's quite, you know, rewarding and powerful, and I suppose it, you know, it makes you feel like it has been like worthwhile.
The mental health and justice team are all clearly passionate about the work they are doing. But this in itself raises a dilemma: how to achieve a balance between research and advocacy.
The question of how research interacts with activism and what the two are doing together, and what point you stop being one and start being another, I think is really difficult. And I think different people have had to confront it in different ways over the course of the project. We might be able to advance a joint position on behalf of a work stream about this is what the factors are. But actually just then go, you know what, I personally think the answer should be.
Our core theme, the balance of empowerment and protection, is it's an emotive theme. So it's an area in which neutrality in some respects is not really an option.
But what is clear is that there is a common purpose, a desire for justice.
Obviously, a project like this we've done a huge amount of work. It's only scratching the surface, but it's at least hopefully giving transparency about things, or giving tools for transparency about things, tools for accountability about different areas, illuminating things which people perhaps had not quite grappled with properly because they were only coming from one perspective. I think the really and critically important thing about this project, it's not just a project for other people, it's a project for everybody.
Even when existing structures and contexts make this far from easy.
The UK is committed to the UN Convention on the Rights of Persons with Disabilities, and the notion of support attached to that document is quite different to the notion of support that is required under English law. And so I think there are some important open questions about, should we stick with our current requirements for support and just try to realise that as far as possible and as well as possible, as justly as possible, or actually do we need to rethink this in a more radical way?
And how do you respect human rights in mental health in communities where laws feel like empty statements without resources or will to implement them?
In Palestine, for example, it's come really up to the forefront as a pressing issue that what does it mean to be advocating for the rights of people with disabilities when everybody's rights surrounding them are also being violated? Many of us understand that when something in international law is written down, the reality on the ground is very different. And what we want to do and know about is whether the law needs to be changed or the reality of the ground needs to be changed. We think that this thing needs to go back and forth. And it's a real question about conceptual clarity, but it's also a question about politics and power.
And communities who are left to pick up the slack are not always the best places themselves.
The ideal of interdependence, the ideal of the community, with the assumption that something like the community is good, that community is good for you, that community is good for your mental health, And I think what we're finding is it's not that easy. If the community is not welcoming, if the community excludes you, marginalizes you, stigmatizes you, violates your rights, is it the place that you actually want to participate in? Same with families. Families have been so supportive. They have been such a great source of support, and yet sometimes they have been a great source of pain as well when people feel undervalued, not valued by them. So again, also these concepts that we often take for granted and consider them as good, support, independence, community, they're not good per se. They are both good and can be extremely violent.
Over the 5 years of this project, things have not always gone according to plan. Sometimes this was a good thing.
Almost from the beginning, we were dealing with unexpecteds. So the first thing was the government's announcement that it wanted to do a big review of the Mental Health Act, which is a big, huge area of potential legislative reform. And of course, this was an important moment for the project, and we needed we needed to get on the front foot on that and put ourselves forward, which we did.
Sometimes the unexpected was more challenging.
If we cast our mind back to the start of the pandemic, when the first lockdown came into place, some of the labs within the university that were doing critical work in terms of vaccine development and so on were able to carry on, but all the other research labs shut down, including our brain imaging facilities. One centrepiece of work in my lab in relation to this project was work that a student that Tony and I supervise, Andrew McWilliams, he's a psychiatrist and has been part of my lab learning how to use these task-based measures of metacognition. Andy did a fantastic job of moving that project online. Obviously not the brain imaging part of it, but the behavioural part of it. He was then able to still ask people to carry out all these same assessments, but rather than doing them in person, he called them up on Zoom and was then able to talk them through over Zoom how to engage with the task. So we still got valuable data, but unfortunately the whole brain imaging component that we had originally envisaged 5 years ago didn't come to pass.
The pandemic provided a huge challenge to us because some of the bits of work we were working on just stopped, like some inpatient observations of inpatient wards. I think, did we improve things? Yes. Is the work finished? No.
There was also the rise of the Black Lives Matter movement, highlighting issues which many on the project already knew needed to be addressed. These were revealed when the Bethlehem Gallery commissioned a piece of work which had unforeseen consequences.
It all started with Mark Titchener and Nuala Kane's collaboration. It's called Some Questions About Us. It's about rights, essentially, decision making. So yeah, that was outside in the Bethlehem. And then after George Floyd happened, about a month later, while we were all in lockdown, it got graffitied with the words R.I.P. Shaney. After the graffiti happened, we got in contact with Shaney's mother, Adri Lewis, and over the past year, we've been working pretty much every week to look at issues of use of force in mental health and the racial inequalities inherent within that. It's become its own work stream in a sense.
He was a good young man, had loads of friends, he was very popular. He hated bullies, he hated injustice.
We commissioned a film, a short documentary, 20 minutes. It was really looking around ideas of restraint. Shaney died because he was restrained by police officers here at the site. The work continues to be used, the graffitied work itself, but also the short documentary film, to further the UK policies around the use of restraint in mental health. It's been shown at film festivals around the world, and it is on the Guardian website, so it's open and free for all so that everybody can see it, which was a very important part of this film because it's about advocacy.
Only this week we had the launch of Shaney's Law, which is a new piece of national legislation focusing on England and Wales to do with use of force. And we were heavily involved in the consultation for that. And I'm really grateful that the project gave me that opportunity to do that.
Kevin also wrote about how advanced directives could help the inequalities so devastatingly shown by Shani Lewis's death.
So in my previous job, I did some research on involuntary admissions and how Black people in particular were disproportionately more likely to be detained, around 3 times more likely. And a previous review found that advanced directives were actually one of the most promising interventions to avert future admissions. So that was something that was really just striking for me, was that I wanted to make that link publicly, and I felt that paper by my colleagues was a really useful and important opportunity to do that.
So you can have a listen.
The Mental Health and Justice Project came to the BBC's attention too. Producer Beth Eastwood is raising awareness of advanced directives through a documentary for Radio 4.
I've made a lot of programmes on medical ethics over the last 20 years, and so this one was absolutely up my street. The problem is that obviously when someone is mentally unwell, do you know that they lack the ability to decide at that moment? So when they're saying no, do they actually mean no? Or could they actually still retain the ability to make a decision? And that whole area was something I made a programme on with King's, Gareth Owen, back 10 years ago. And he was then with others looking at how is decision making impeded during different types of mental illness. It makes me then think, gosh, if there are people saying no to treatment when they've lacked the decision they would have wished they had had treatment, is it unethical to ignore this and just carry on as we have? So it's a really rich area for research and for a programme.
So what's next for the project?
I think that we, in a sense, just scratched the surface. I mean, 5 years sounds like a long time, but actually, in terms of the conceptual work that was required to get to the stage of having the right kind of tasks, the right kind of metrics, the right kind of measures that we can easily study in the lab, and then build a bridge from the lab to the real world where there's a messy situation of people making difficult, emotionally charged, one-shot decisions about things that matter hugely in their own lives. The roadmap is in place for where the bridge needs to start and end, and we just need to continue building from both sides.
I guess the hope with understanding metacognition is that if we can help a person reflect on their own thinking, on the accuracy of their beliefs and perceptions, we can help them make better decisions. But ultimately, we want to give the individual back the ability to make decisions about their own lives.
We know that, in some form or other, government's committed to bringing in advanced choice documents, and so, it's likely to become something that's a bit, on the agenda, and we want to get ready for it. And so what we would hope to do is set up the first advanced choice document clinic in SLAM, and this clinic would be run by a multidisciplinary team with psychiatrists, psychologists, service users, and specialist nurses. And it would offer service users the opportunity to self-refer and get advice about how they could make an advanced choice document, to get support with it, to liaise with their clinical team. And we also think it's going to be somewhere where we can develop training, sort of a training program for people who want to learn how to support people to make these documents, and education materials, which could then be rolled out nationally and help other people set up similar clinics and develop more resources. What I'd really like to see is sufficient resource supporting legal changes around advanced choice documents.
A lot of the people involved in mental health and justice are not just researchers, some of them are also clinicians, but a lot of us are involved in training, and training the trainers, we call it, right? Finding there's a huge number of people out there in civil society who are applying these concepts, who are applying the legal standards, and they need ongoing training. So actually just yesterday, Alex Ruck-Keen and I were training a big national meeting of professionals who are working in eating disorders units in the NHS. And so we were going through some of the issues around capacity, some of the challenges in applying the legal standards to that particular patient population. And I'm sure that kind of work will continue and be informed by both the collaboration and the research results from Mental Health and Justice Project.
One of the key findings, at least for me, was that while of course we found the various and multiple layers of exclusion from the community, people had no lack of imagination in terms of what they thought community should look like. And that showed me how important it is for whether it is policymakers, lawyers, advocates, activists, to actually take that time, invest that time to speak with people with lived experience.
Team members are hopeful that the project will make a difference in the future.
I think our project shows that justice goes beyond the legal understanding of justice. It would be wrong to assume that it can just be achieved by pointing the fingers at government, at policymakers. Everyone in the community has to ensure, has to participate in a way that people, also those who are most marginalized and excluded, have a meaningful life, that they can lead with dignity and in a flourishing way.
This is a project that has been actually quite hard to end. I think because it's generated a lot of emotion. Maybe in a way the legacy is that this kind of ideas-led project has left a legacy of a way of thinking and a kind of confidence that you can do it. I also feel proud that we basically delivered on what we said we'd do. We set out our hopes and our aspirations, and looking back now, I think we've not only have we met them, I think in some respects we've exceeded them and generated the possibility of a legacy.